Well, thanks. And hopefully you can hear me now. Do we got sound? Can you hear me? Excellent. Okay, well, such a joy to be with you all today. And I apologize I could not be there in person. But the reason I couldn't be there in person is, interestingly enough, the subject of my remarks today. So, if we're going to look at this punctuated equilibrium, if we are going to look at digital health, where to invest, where to develop, you're going to need some use cases. So I want to start with a complicated use case for you. My mother, 80 years old, had her birthday on July 15th of 2022. I flew from Boston to LA to be with her. We had planned to go to a Hollywood Bowl concert, music of Leonard Bernstein. She was going to walk a mile, have dinner with friends, the usual thing that she would do as an 80-year-old and very healthy and fit person. I arrived in LA, went to her house, found her febrile, a little confused, and dehydrated. So, of course, ask yourself the question. If you find an elder female a little bit confused and dehydrated, what's the first thing that comes to mind? Well, probably could be a urinary tract infection or early urosepsis. Now, of course, I'm a physician and have been for 40 years, so I could make that visual assessment and understand based on my experience and based on what I know from my sort of anecdotal training over those 40 years, what to do, where to go, and who to call. Typical person's not going to be able to figure that out. Do you call 911? Do you call the primary care physician? Do you call your relatives? It's extraordinarily hard and confusing to triage the healthcare in this country because we just don't have quite the tooling we want and need. And one hopes that as you look at some emerging companies, and there are several, they'll help with this care traffic control of where to go, the right time for the right care. Okay, so I make the assessment. Her vital signs are stable. Probably we can start this treatment as an outpatient. So I call her primary care office, arrange for an emergent visit, get in, do labs. Her creatinine is fine. Urinalysis shows, yes, a very significant urinary tract infection. We decide to give her ceftriaxone, a cyclist, it's basically an antibiotic that is pretty good in its coverage, and we give that intramuscularly. And here's the other interesting question. For an 80-year-old healthy person with certain kinds of phenotype and genotype and exposome, is it rational to start with outpatient treatment or not? Does anyone know? Could you look at 10,000 patients like that and decide that outpatient treatment is a good place to start? Well, again, this is all based on anecdote and personal judgment, and I was going to be with her, so it seemed relatively low risk to give her an IM injection and then continue to follow closely. Because really, sending an 80-year-old to a hospital is not something you necessarily want to do. Over the course of the next 12 hours, her clinical state declined remarkably to the point where she was almost not responsive. 2 in the morning, I call an ambulance. Have to explain, I'm a physician, remember, to the ambulance folk, here's her clinical history, here's her clinical course, here's probably where she should go. Okay, well, I trained in LA, so I happen to know every hospital and I know all the various clinicians, and I was able to create that direction. Again, think about this. If you are just a consumer of medicine, and even if you are told call an ambulance, even just navigating that process is not easy. We get to the emergency department. I know everybody there because I train there. I say, we should not only do a full sepsis workup, we should probably evaluate her mental status changes because they're pretty severe. And of course, again, what's the standard of care? Should you order a CT? Is a standard 80-year-old urosepsis workup inclusive of imaging, and what imaging, right? Again, we don't really have that as a set of decision support tools that are just executed based on the history of thousands of patients like this. We do the CT scan, it shows a ring-enhancing lesion in the right occipital part of her brain. Now, a ring-enhancing lesion could be a tumor, could be an abscess. Well, again, do you have the machine learning that can look at thousands of similar kinds of images and say, oh, well, based on this image, it's probably more likely infectious than tumor because that ring is really typically more abscess-like? Well, the answer is no such tool really exists. So first thing we do, call neurosurgery. Neurosurgery decides to do a stereotactic biopsy of the area of her brain that's affected. They pull out 3 samples. The pathologist at the hospital where she was being treated, which is a Cedars-Sinai affiliate, a very good hospital, pathologists were not able to figure out quite what the tissue indicated. I mean, it's inflammatory, but is it infectious? There don't seem to be white cells. Gram stains are negative. Doesn't seem to be a tumor. Very confusing. So, of course, I asked the question, could you send the biopsies to the neuropathologists at Mayo Clinic? And well, Mayo has a full digital pathology suite, and that we could take the slides prepared in Los Angeles, digitize them at high resolution, get those digital images to the Mayo neuropathologists, their various visualization and AI tools. And I was told, well, we don't really have capacity to do digitization and transmission of that kind of image quite yet. Okay, so it's coming. Digital pathology going to be a pretty important thing over the next 6 quarters as that industry grows. But for now, we sent the material, the tissue itself, to Rochester, Minnesota. Neuropathologists evaluated it, did all kinds of staining, said, you know, this is infectious. And what do we treat it with? Well, again, the question is, for a not definitive organism, what antibiotics do we use? Well, we decided that we were going to use meropenem, very powerful antibiotic, and vancomycin. My mother was on those antibiotics, and this abscess, which was 17 by 11 millimeters, shrank to 12 by 6 millimeters, seemed to be getting cured. She was also on Decadron, which is a steroid you give for patients who have a lot of brain swelling. You want to reduce the brain swelling. As the Decadron was taken down in dose, suddenly her entire body erupted with urticaria, an allergic reaction. Turned out she was actually allergic to the antibiotics she was given. It's just the steroid was covering up that allergy. Okay, so then she was given all the usual sorts of things one gives for very severe allergic reactions. Her body was in a very significant inflammatory state, and she developed clots in both of her arms. In fact, clotted off her internal jugular on the left. Okay, well, what do you do when you have clots all over your body? Well, you want to anticoagulate. So they gave her Lovenox, a kind of anticoagulant, low molecular weight heparin. Well, of course, she actually had her hip replaced a few years ago and had, of course, all of the trauma that would be associated with hip surgery. 2 days after being anticoagulated, she had a massive bleed in the area where she had had her hip surgery a couple of years ago and effectively lost half her blood volume. Her hematocrit went from 34 to 17. Because in effect, it would be like having a radiator burst and the car is going to overheat. Well, her heart didn't have enough blood to pump. She went into AFib with rapid ventricular response and a near cardiac arrest. Ended up in the ICU on Levophed, a very potent medication to raise your blood pressure. Ultimately, came out of all these complications, is probably going to be discharged from the hospital in the next 48 hours. I will transport her to Boston. I tell you that story because think about all the complications. Think about the journey she was on. Think about the potholes that she encountered on that journey. And ask yourself, if we had products that are providing us with decision support because we're looking at the patients of the past, whether that is historical treatment of certain diseases, image analytics, pathology analytics, these are the kinds of things that we're lacking but certainly need. And now, of course, the interesting question. She is going to need some post-acute care. I will be delivering that post-acute care in the home because it turns out that getting access to post-acute care in Boston right now is just really hard. This sort of period of post-COVID new normal, just there are no beds available, staffing is light, It's just really challenging even for hospitals to do discharges because there's no place for the patients to go. And so figuring out how to deliver post-acute care in the home. What is the equipment you need? What is the staffing that you need? What's the level of talent you need? Is it a home health aide? Is it a private duty nurse? Has required a lot of navigation. So as you look at more home-based delivery, I'm thinking, and Mayo has experience with this, you're going to start seeing more formalized, completely protocolized emergency department evaluation in the home, acute care stays in the home, post-acute stays and rehab with PT in the home, and take the guesswork out of it. Make it predictable. Make it a kind of rubric or template that is just clearly followed based on a definitive set of qualifications for the patient to get enrolled in such a program. So there's my mother's story. Now let me tell you just a little bit about what Mayo has done as we think about some of those products and services and solutions we need for the journey I just described. Mayo has 150 years of patient data. It's about 10 million patients birth to death, longitudinally, structured, unstructured, omics, digital pathology, images, and telemetry. From January through April of 2020, we moved all the structured information from 5 different EHRs by history into Google Cloud and de-identified it in a container under Mayo's control. From April through August, we did the same thing with unstructured data. All the notes, all the pathology reports, all of the kinds of diagnostics that don't have a lot of structure and are mostly text. The trick with doing that is de-identification of unstructured information is hard. You can imagine that if a note said something like, this CEO of a leading software quality and usability analysis firm in Salt Lake City, I didn't say a name, I didn't say a company, but you could infer that I was just talking about Adam. These are the kinds of problems you have with unstructured data. And you have to look at natural language processing and machine learning methods to remove proper nouns or change them to something else. Job roles, geographies, familial relationships may need to be altered. So we did all that. And then we started to add images, and we did de-identification of images through optical character recognition. If there's an imprinted card on an image itself, you're going to have to redact that. And then even start to think about if you have images of the face, how do you redact that? And omics, biomarkers as opposed to full sequences, right? So you do all these things. We ended up with about 10 petabytes on 10 million patients. And then we started to bring collaborators, joint ventures and partnerships into our cloud container so that new products and new services could be developed from this large corpus of multimodal de-identified data. As of today, we have about 150 different partners that are working with these large data sets to create novel products and services. And given that I'm speaking to a number of folks who are entrepreneurs and in the investment community, the number of, say, new funding opportunities, because these companies created products with Mayo data, with Mayo experts, and then went out to seek funding, they were pretty successful in getting their Series A and Series B funding on the novel products that were created. But here's the question. Is 10 million longitudinal patients sufficient to create what I'll call useful, unbiased, and fair AI models for the world? The answer is it's not. So we have also partnered with other organizations. 2 months ago, we signed an agreement with Mercy Health to bring 15 million patients from their cohort, which is mostly Missouri, Arkansas, and Oklahoma, to our AI factory and validation capabilities. We signed an agreement with Sheba in Israel. We have multiple agreements in process, Europe, Canada, all to create a distributed federated data network where we have the capacity at large scale to develop new AI models and validate them. So the reason I give you that is because if you work with many academic medical centers, it's just devilishly difficult to do an industrial collaboration or a co-development. What Mayo has tried to do is make that process frictionless so that we can take an idea and take a company and within 2 weeks begin doing co-development with full access to this de-identified 10 million patient set and then expansion of that data set as I've described in a more federated fashion. So that means that we can, again, this notion of punctuated equilibrium, suddenly we get this capacity to run AI to scale without friction, producing about 60 models over the course of the last year. Some are in FDA and CE clearance, some have been designated breakthrough. And it gives us this opportunity to create new companies. A lot of this work is being done outside of Mayo Clinic, just with the advice of Mayo Clinic experts and the de-identified data. So we've spun out companies in the areas of cardiology, neurology, radiation oncology, radiology, behavioral health, and these kinds of things. So what you hope is you look at these next 6 quarters, that we're going to start to see workflow integration of useful, fair, unbiased machine learning algorithms that take the guesswork out of clinical care and the care process by augmenting human capabilities. You'll also see these new care delivery models, as I've described, more home-based, even high acuity care. Mayo Clinic has worked with a company on launching home-based high acuity care. Kaiser has also worked with us. Together, Mayo and Kaiser have now discharged about 10,000 patients with high acuity, serious and complex illness from their living rooms. And what have we found? Quality is the same, safety is the same, outcomes are the same, cost is less. Patient satisfaction, a net promoter score of 97%. Incredible patient satisfaction. And then readmission rates, 25% less than a typical brick and mortar hospital. And nosocomial infections, falls, mistakes, and errors basically eliminated. So you're starting to see, new care delivery models work, and especially in a post-COVID new normal, where there are staffing challenges, the great resignation, the great realignment, there are budget challenges. These new models to deliver care at a distance are going to be essential. Before we open up Q&A, maybe just the last thing I'll comment on, sometimes we need technology change. Okay, look at the last couple of years. We've got cloud, storage, compute, we've got APIs, we've got standards. The technology at the moment, not the rate limiting step. It's actually good enough. Sometimes you need policy change, like the ability to reimburse care at a distance. This notion of a home hospital, if it's non-reimbursed, is not going to go forward. Well, good news, during COVID, there were enough regulatory waivers that the reimbursement of a lot of these virtual care models is here and probably will be around for a while. Policies might also include site of service. Who can practice where, at what level? And a lot of that regulatory change has empowered new models and the ability to bring new technologies into the home. But most important is probably not technology and policy, it's culture. And what I would argue is COVID has taught us that our consumers want more care, and they want it in non-traditional ways. They want telehealth, they want digital health, they want the devices they wear, the devices in their home, because they discovered how convenient and easy it was in a time of COVID to get care that way. Now, it's not working for everybody, of course. We triage about 30% of our patients to a home-based hospital alternative because there are certain kinds of unstable patients you wouldn't put in a home environment. And of course, we need to think about equity, and we need to think about broadband availability and trust and a whole variety of issues of how do we serve those who may not have the income, the literacy, the technological savvy. Do we give them care navigators of some kind, sort of digital aids, if you will? So a number of issues to solve. But culturally, I think we also have a mandate for this next generation of digital health products. So there you go. It's what I would call a perfect storm for innovation, that punctuated equilibrium. And my mom's case that I described to you at the beginning, although her outcome will be okay, the process could wildly be improved. And I look forward to the new products and services of these next couple of quarters to make it so. Open it up to your questions.
So Dr. Halamka is able to hear the audience. We have a couple of roaming mics. We have time for maybe 2 to 3 questions. And again, a couple of mics. Go ahead and just raise your hand. Our next panel participants, if they don't mind just meeting in the corner, this corner over here, please.
So don't be shy. You can ask anything.
John, thanks for your leadership over the years. It's been tremendous to follow your career. Culture is led by leaders. And I think about, the busy chief medical officer who's working on day-to-day, just trying to get hospital operations or clinical operations. How are we going to get them the proof cases, the courage, the ability to adopt some of these advanced technologies like AI? How do we build those leaders in each health system that are willing to push the boundaries?
So what a wonderful question. So part of it is that it is up to all of us to openly publish our experience so that there's a sense of, oh, there's value proposition there. That value may be increases in quality and safety or better outcomes, or reduced human burden at a time of huge burnout and retirement and resignation. And getting that story out is something, Mayo has tried very hard to do. What couple of papers that you'll see are looking at, well, we put an algorithm into, say, radiation oncology. We can actually take 80% of the human work out of the delivery of care, which doesn't mean fewer radiation oncologists. What it means is the radiation oncologists can now spend more time with their patients instead of sitting in a dark room doing physics. And they have the opportunity to still overview all the algorithmic output, but it gives them a better quality of life at the top of their license. So that's the story, the value proposition that encourages the entire ecosystem to go forward with this, because otherwise we're not going to have enough clinicians to see the patients who need their care, and we're not going to be able to reduce the burden that our clinicians have felt over the last 3 years.
The question is, how do you access that data if you're not part of Mayo Clinic or one of its affiliates?
Right. And so, as I say, what we have is the ability to bring in partners in industry and academia into our controlled environment, which is a sub-tenancy of Google Cloud, where you bring your tools. And so we do this on a daily basis. We also have an accelerator program. And we have brought in 2 classes in that accelerator program who are given access mentoring and that kind of thing. So either, certainly anyone can follow up with me, but this was not just to tell you the story about Mayo Clinic. What I am hopeful for is that we're going to see across this country, across the globe, more collaboration and partnership, more willingness, using like a model that we have of de-identified private data and bringing partners in to create new products and services. You hope that kind of model is going to just be much more commonplace. So it won't just be Mayo and a couple of other centers offering that kind of thing.
Thank you again for the wonderful talk. All right, you touched on privacy a little bit, and that seems to be a common theme across health and all other enterprises with data leaks and patient data getting out. What assurances can we provide our patients and our leaders that their information that's being released and being shared and being used to do these algorithms that are going to help improve their care is actually being safe and protected?
Well, again, an excellent question. And so having been in the industry for 40 years, there's no such thing as perfect security, right? Security is an ongoing process, not a project. You're never quite done. The approach we've taken is what I'll call a multi-layered defense. If you de-identify the data, and by the way, that de-identification has been certified by Vanderbilt University, Dr. Brad Malin, as 99.6% de-identified. And then it is in a cloud that is under your control with access and auditing all by Mayo. And when a partner is brought in to work with the data, they cannot take the data with them. They cannot take another database from the outside world and try to link it with the de-identified data to try to re-identify the data. The only thing that leaves these secure cloud containers are algorithms, visualizations, products, these kinds of things. So our promise to our patient is the data never leaves Mayo's control. It's de-identified, it's audited fully, and we have a rules of the road that minimize the risk of re-identification. And there's no way the data is going to just go out into the world where bad things could happen to it. So that's our approach, but obviously continually refined and improved.
We have time for one more question. Go ahead.
I'm going to go for my second question. Mike Kramer again. Hey, if you had to list the top 5 world's largest health data aggregators, and then where are they going with their size and scope with that data?
So, it's really interesting. A lot of the data that is aggregated today is administrative data, right? Claims data, script data, that kind of thing. Problem is, it's not, I mean, it may have breadth, it just doesn't have depth. And so, what do you do with billions of claims if you don't understand the outcomes? You don't understand the clinical characteristics of the patient. You don't have the phenotype and the genotype. So, I just think as an industry, we have to focus on this notion of creating ethical reuse of privacy protected data that has great depth as well as breadth, and has the multimodal data types I've described of images, telemetry, omics, and digital pathology, and not just administrative data.
Excuse me, Dr. Halamka, we really appreciate you sharing such insightful thoughts with us today and personalizing that your speech or your keynote with your mother's situation. We have great admiration and appreciation to you, and look forward to speaking with you again here in the near future. Everyone, thank you, Dr. Halamka.
Well, have a great day and a great rest of your conference. We'll see you soon.